Should we start? I think as people are joining, Lakshmi and is Dr. Arjun Das also going to be there? Hello? Hello?
Yes, sir.
I think Lakshmi might have reached home. She is not there.
Reached home. I have reached home.
Okay.
Right. Okay.
Good evening, everyone.
So Lakshmi, can you please start?
Yes,
Then,
sir. Yes, sir.
then-
Hello?
Hello.
I think he's probably converting from.
Yeah.
Yeah, sir, I'm here. So, good evening, everybody. At the outset, I welcome all of you on this, on the eve of the celebration of the Rare Diseases Day. And when Professor Gagandeep told me that we should celebrate the Rare Diseases Day by having one rare disease every month and discussing it in detail. And this is his brainchild. And I then immediately contacted Professor Vinayan, who is agreed, who runs the best neurometabolic unit in the country in Amrita. So is my very close friend. I requested him. He said immediately yes. And so we are on in the process of starting this monthly webinars on rare diseases. Professor Muralidharan Nair, in spite of his busy schedule, I welcome you, sir, to join this meeting. And as usual, the president and the secretary, the most dynamic president and the secretary of the Indian Academy of Neurology, I welcome you both on the eve of this Rare Diseases Day. And over to Professor Gagandeep and Professor Meenakshi for their comments and before we start the session on. Thank you.
Yeah, without much ado, I just want to say thank you, Dr. Lakshmi. I just want to say that Dr. Lakshmi rang me up some days ago, and he felt that this rare diseases thing is something that is extremely important. And this is something where we can really collate our efforts and collaborate and learn much more, because rare diseases, as the name suggests, are so rare. And if they're so rare, then we need to have, once we do find some rare disease, or there are experts in rare diseases, then we need to get it across the whole country, not only across the country, but perhaps the world. And I think this initiative is something that will, in time, not just attract people from across India, but people from across the world, because as the name suggests, rare diseases are rare, and everyone would like to see rare diseases, and everyone would like to learn from the experience of someone who has diagnosed a rare disease and treated a rare disease. So with this, I must congratulate Dr. Lakshmi for this brilliant idea, and also for his plans to take this forward. I would also invite comments from Dr. Meenakshi Sundaram, the Secretary of Indian Academy of Neurology, and then pass it on to the speakers and the experts for today, Dr. Vinyan and Dr. Vaibhav Anand. So, Dr. UMS.
Thank you.
Yeah, and a few words from Dr. Nair too. Right. Sorry. Yeah.
Thank you, Professor Gagan, and good evening, Nair sir, and long time we met in person, and it's wonderful to see Vinayan, and thank you, Lakshmi, for organizing this. We have been brought up with this saying that if you hear hoofs, think of horses and not zebras. But if a zebra does come, we must know how to identify it. We can't always keep thinking about horses alone. There might be zebras too. and it's important to identify the zebras. As you get older in the profession, and Dr. Nair is here, and most of the people here are very senior people. You know that you were forced to make those rarer diagnoses more often because these patients come worked up and elsewhere, and they have so many reports. So there's always an excitement in making a rare diagnosis and looking at something that's 1 in 1 million or 1 in 10 million. So Vinayan is very well known for his neurometabolic work and epilepsy work. And hi Vinayan, and we look forward to the presentation. Thank you. Can we request Dr. Nair to...
please, and then on to Dr. Vinayan.
I thank the President and the Secretary of the Indian Academy and Professor Lakshmi for taking this forward, and I think it is a brilliant idea, as Dr. Jagan has already told. And rare diseases are a real challenge in neurology because normally we go by the adage that common diseases are common. But then we have to face in our practice uncommon manifestation of common diseases, then uncommon diseases, then common manifestation of uncommon diseases. So there comes the real challenge in diagnosis. And majority of the rare diseases are not well covered in our curriculum. And many of these diseases, as Dr. Binian will vouch, if you read your pediatric text, the Farfar and what is that, Nelson, is full of various syndromes, and it can come in any fashion, the manifestations. And the common condition itself may be unmasked by a rare diseases, with the expression being epilepsy or autism or whatever. So when I was in the Sri Chitra, the executive president, they was very much interested in starting the autism thing there, and in the whole Kerala, they wanted to start nodal centers. That's how we got involved in the autism. And then since autism is really a pediatric kind of issue, and we are adult neurologists are not that much exposed. So then we said we have to have a pediatric neurology going in that. And in that way, we could recruit a pediatric neurologist. Of course, nobody from the pediatrics came, but then the adult neurology motivated person was brought into the neurology stream. And now they are having a huge project of their own on autism and different diseases. So as Meenakshi told, you have to consider zebras on a rare occasion, because rather than, so it's a real challenge. And I would straight away ask the speaker to get into the real nitty-gritty of the case. And it's a big challenge, the rare diseases. And that was the main focus to start this thing. And I really thank all the previous presidents who helped us in forming this subsection. And especially Dr. Gagan for rekindling the interest and rejuvenating. And Professor our Lakshmi taking it forward with especially he's doing it in the secrets of neurology, which I am listening. Many of those cases are really very challenging cases. And also it brushes up your entire differential diagnostic approaches to all these diseases. So thank you so much for giving me the opportunity to share some of my thoughts. Thank you so much, and wish all the blessings and success for this program. Thank you.
Yes.
Lakshmi.
Vaishak, over to Vaishak Anand to take over, please.
Okay. So my slides are visible.
Not yet, sir.
You share.
Now?
Yes, sir.
Yes.
Okay. So at the outset, I would like to thank IAN and Rare Diseases subsection for providing me the opportunity. So as we all know, today is the Rare Disease Day. So on this occasion of Rare Disease Day, we'll be discussing a case of an infant with a rare disease, which we manage and are still managing at our institution. So rare disease, there is no consensus or definition for rare diseases. The definition of rare disease varies between country to country from even time to time. So WHO defines a rare disease as a prevalence of a disease which is with a prevalence 1 or less in 1,000, but ICMR defines it as less than 1 in 2,500. So almost 7,000 conditions are labeled as rare disease, and more than 600 million people are affected with rare diseases worldwide. That's the estimate. So although these diseases are considered rare individually, collectively their number is significant. And as a practicing pediatric neurologist, I can vouch that these diseases are very lately diagnosed or mostly misdiagnosed or undertreated. So these are the terms that we already heard when we were UGs, like when you diagnose a rare disease, you are rarely correct. Rare presentation of a common disease is more common than the common presentation of a rare disease. So I think as neurologists, we should be taking this with a pinch of salt, because as I already told, rare diseases, they may be individually rare, but collectively they are not that uncommon. And at least the common rare diseases we should be knowing. So I'll be going to the case unit. We have a 4-month-old baby boy. He was born out of a non-consanguineous marriage. The child was born out of an IVF pregnancy, but otherwise uneventful antenatal and postnatal periods. He was exclusively breastfed. And he was gaining milestones and weight till 4 months of age. At 4 months of age, the 3rd dose of pentavalent vaccine was given. And then very next day, he started having fever, which was followed by vomiting. Subsequently, he was lethargic, he became drowsy, and he had refusal of feeds. But otherwise, there was no history of any fall, any toxin ingestion, any drug intake, no seizures, or any abnormal movements. On examination, the vitals were stable, and anthropometry also, his weight, length, head circumference, everything was up to mark for 4 months. And general examination showed that his anterior frontal lobe was flushed with skin without any bulging. There were no dysmorphic features. There were no skin rash or alopecia, no petechiae, bruises, ecchymoid patches, and the external genitalia also was normal. And the system examination showed that he was having poor suck and swallow. Active and passive tone was less. He had axial and appendicular hypotonia, and the DTRs were not elicitable. But there was no hepatosplenomegaly. So basically, we have a 4-month-old, well-thriving baby who presented with fever-associated encephalopathy without any proper localizing sign, except that he is having encephalopathy. So in such a scenario, the most common condition to the most common etiology to be considered is an infection-related thing, like maybe a meningitis or meningoencephalitis, or even when brain is not involved, infants can have lethargy, like even in sepsis, pneumonia, diarrhea, etc. Also, children, young infants can become lethargic and look like that they are having meningitis or meningoencephalitis. So, infection to be ruled out is the first thing. If infection is ruled out, then the next possibility is an IEM, independent error of metabolism, which can present around this age. The other causes are hypoxic ischemic encephalopathy at 4 months, 3 to 4 months. Sometimes children can have apparent life-threatening events leading to a hypoxic event. A cerebrovascular accident should be thought of, like an IC bleed, most commonly the late onset vitamin K deficiency, hemorrhagic disease of newborn leading to an IC bleed, diarrhea and vomiting leading to a CSVT, a stroke, or even a traumatic brain injury should be ruled out. And endocrinologic causes like congenital adrenal hyperplasia, unless we think of, we'll be missing that. So with this, we proceeded with the investigations. So his routine evaluation was showing hemoglobin was normal. He was having normal platelets and leukocyte. Platelets were a bit on the lower side. Otherwise, his liver function tests were normal. When we did the blood gas, it was showing a pH of 7.27, which was very low, with a bicarb of 9, with an anion gap was 25. His serum glucose was normal. Again, his arterial lactate was very high. It was 4.4. Ammonia was normal. He had hypokalemia. He had hypocalcemia, and urine ketones were negative. We did the CSF, which showed normal cells without any other infectious parameters. So after the initial point of care investigations, we have a child with fever with encephalopathy, with investigation showing a high anion gap metabolic acidosis with high lactate with normal glucose. So now we have ruled out an infection related cause, and now we are almost sure that we are dealing with an inborn error of metabolism, IEM. So now, when I say about IEM, all of us will be overwhelmed with all the pathways, cycles, and all we already have marked up in the first year, and was very difficult to remember those pathways and all. So what I'll do is I'll just summarize the major energy metabolism pathway in a single slide, so that at least this case can be discussed. So I'll be starting from glucose. So everyone know glucose is essential, and there should be a consistent level of blood glucose always. Glucose, which is a 6-carbon, through the process known as glycolysis, glucose will be split into 2 molecules of pyruvate. So pyruvate is a 3-carbon molecule. Now, the pyruvate, the fate of pyruvate is that pyruvate, glucose is in the cytoplasm. So again, pyruvate is also in the cytoplasm. In this picture, this is the cytoplasm. Now, pyruvate will be crossing the mitochondria, and in the mitochondrial enzyme PDH, that's pyruvate dehydrogenase, will be converting pyruvate to acetyl-CoA. So pyruvate is a 3-carbon compound, and acetyl-CoA is a 2-carbon compound. Acetyl-CoA is like the center of our attraction. We can say he's our hero. So please have a look at him. Acetyl-CoA can have 3 destinations. Okay. So acetyl-CoA can combine with OA. OA is oxaloacetate. Okay. Again, OA is also metabolized from pyruvate through the action of pyruvate carboxylase. Now, OA and acetyl-CoA combine together and enter the tricyclic acid cycle, which is otherwise known as Krebs cycle. Okay. From the Krebs cycle, we know there's the end product ATPs will be produced, which is essential for the sustenance of all tissues. Now, apart from this pathway, acetyl-CoA can have other actions. Now, in the liver, most of the acetyl-CoA is utilized to produce ketones through a procedure through a process known as ketogenesis. The fate of acetyl-CoA is it may be, hello. The other fate is that it can be channelized for fatty acid synthesis also. Now, acetyl-CoA, we saw it is coming from glucose metabolism. Now, glucose cannot supply all the acetyl-CoA needed for the body needs. So we have free fatty acids, which through a process known as beta oxidation will be producing acetyl-CoA. Another pathway is amino acid metabolism. Again, that they also can produce acetyl-CoA. So apart from this, the pyruvate, as I already told, will be converted to acetyl-CoA in the mitochondria, but that needs oxygen. So in the in a situation where oxygen is not available, pyruvate will be undergoing anaerobic process and will be converted to lactate by the enzyme LDH in the cytoplasm. Now, what happens to the OA that has been in the mitochondria? OA can be channelized to a procedure known as gluconeogenesis. So as the name implies, that means that production of new glucose. So this is the pathway known as gluconeogenesis. So it's just the reversal of glycolysis. Glycolysis, glucose converted to pyruvate. The gluconeogenesis, pyruvate is converted back to glucose. That's known as gluconeogenesis. Now the other source of glucose is glycogen, which will be from glycogen, a process known as glycogenolysis will be producing glucose, which is then released in the bloodstream. Now, as I already told, acetyl-CoA is the central figure of a pathway. It's a 2-carbon compound. Now, the free fatty acid, all free fatty acid will not be producing acetyl-CoA. Some odd chain free fatty acids will be producing a 3-carbon compound, because if there are 11 carbon compounds, it will be converted as 4 acetyl-CoA, and one left is a 3-carbon compound, which is known as a propanol-CoA. Again, 4 amino acids also, namely valine, isoleucine, threonine, methionine. Their metabolism also produces propanyl-CoA. So propanyl-CoA, we can say it's kind of a cousin of acetyl-CoA. It's just that it is 3 carbon. Now propanyl-CoA will be converted to methyl-malonyl-CoA, then to succinyl-CoA. Now this succinyl-CoA again goes to the tricyclic acid cycle, and then the cycle continues. So this is just the overview of energy metabolism pathway. IEMs, there are many classification schemes of IEM, but practically IEM can be divided mainly into three. Group 1 is what we call as small molecule disorders or intermediate metabolism pathways. Here, what happens is there is intoxication due to accumulation of toxic compounds. For example, aminoacidopathy like MSUD. MSUD is maple syrup urine disease, organic acidemia, urea cycle disorders. So in these disorders, there will be the deficiency of an enzyme, particular enzyme in a pathway, and due to the deficiency of that enzyme, the proximal metabolites will be getting accumulated, which are toxic to the tissues, mostly brain. So in the urea cycle disorders, it's the ammonia. In organic acidemias, it's the organic acids. In aminoacidopathies, it is the keto acids. So this accumulation of the toxic compound is the primary nuisance in these cases. These are known as small molecule disorders. Second one, disorders involving energy metabolism. As I already told, these are the energy metabolism pathways: glycogen, gluconeogenesis, fatty acid, etc. So mitochondrial cytopathies like Krebs cycle defect, pyruvate dehydrogenase deficiency, cytoplasmic defects like glycolysis pathway defect, glycogen metabolism defect, FAOD. These all, if there is any deficiency in the pathway of any this pathway, they can lead to reduced energy. So the problem is that this will not be confined only to brain. This will be affecting all tissues, namely muscle, heart, etc. also. In the first group, small molecular disorders, the peculiarity is that these will not be presenting on day one of life because this accumulation of toxic compound need to be there. So once the child is in, the child when he or she is in utero, the placenta will be taking care of the metabolism. So there is no accumulation of any toxic compounds. Once the child is born, up to 1 or 2 days, the child is okay. But then from breast milk, protein metabolism starts. Then the toxic compound get accumulated, which can cause present later. So at least 1 to 2 days of gap will be there before presentation and birth in small molecular disorders. Now the third group is storage disorder like lysosomal storage disorder like Gaucher disease, mucopolysaccharidosis, paroxysmal disorders, etc., which usually will not be having an acute presentation. They are like chronic, so we'll not be touching on them. Now coming back to our pathway. So glucose need to be maintained in the blood always. If glucose is not there, like we are in a fed state, it is from the intestine, glucose is getting absorbed and blood glucose level is maintained. Once we are fasting, there is no glucose coming from the intestine. So what happens is glycogen will be starting this process known as glycogenolysis, by which, so glycogen is stored in the liver. Through glycogenolysis, glucose is produced, which is released into the bloodstream, and then other tissues can absorb it. Now, once glycogen stores are also depleted, then the other gluconeogenesis pathway sets in, where even amino acids, other pathways all sets in, and they start producing glucose through gluconeogenesis pathway. Now, that also has a limitation. Now, once the glycogen stores are depleted, the other major energy production is from the free fatty acids. Okay, free fatty acids will be producing acetyl-CoA. This pathway is very important for CNS because brain is an organ which can utilize only glucose. It cannot utilize free fatty acids directly. So if there is less glucose in the blood, that will be affecting brain very badly. So brain needs a alternate energy source. That alternate energy source is ketones. So brain, the liver will be producing ketones, which is released in the bloodstream, which will be going to the brain, passing the blood-brain barrier. And this the ketones, mainly beta-hydroxybutyrate, acetoacetyl, they will be again through a process known as ketolysis. They will be producing the end product again, acetyl-CoA. Now that acetyl-CoA can go into tricyclic acid cycle and produce energy, and brain can utilize it. So that's the importance of ketogenic pathway for brain. So if there is any defect in fatty acid oxidation pathway, which is known as FAOD, fatty acid oxidation defect. So in the setting of hypoglycemia, when glucose is not there in the blood, body will not be able to produce ketones due to the defect in this pathway, and can lead to hypoglycemia and severe lactic acidosis, leading to severe encephalopathy. So that's the importance of ketogenesis. for most of the IEMs, clinical examination will not be that much contributory, except a few, like dysmorphic features will be present in mitochondrial diseases like pyruvate dehydrogenase, glutaric aciduria type 2, etc. Macrocephaly may be present in glutaric aciduria type 1, L2-hydroxyglutaric aciduria. Now, one of the most important features is skin rashes and alopecia may be present in biotinidase deficiency. So, if a child is in the ICU with suspected organic aciduria or metabolic acidosis and you are having skin rashes and alopecia, then biotinidase deficiency should be suspected. Jaundice in case of galactosemia, Paul G. Cataract again in case of galactosemia. Investigation in cases of suspected IEF. So, this is there's a mnemonic which is known as GLAC. This is the point of care investigation that should be done in all cases of suspected IEF. I'm sure all institutions will be having these investigations at the point of bedside. Mainly GLAC is G for serum glucose, E for electrolytes, and then can calculate anion gap, L for lactate, ammonia, arterial blood gas, K for urinary and serum ketones. If at all serum ketones are not available, at least urinary ketones. TMS, GCMS is needed, but I know that it's not available in all centers, at least as point of care. So most of the in a case of suspected IEM, if you're doing this GLAC, most of the cases, at least you can classify as which group of IEM it is fitting, like whether it's an organic acidemia, whether it's a urea cycle disorder. You may not be able to pinpoint which etiology particular disease is that, but at least grossly you can classify that with this point of care investigations. So coming back to our case had metabolic acidosis. So we can approach that from metabolic acidosis point of view, or we can approach from increased lactic acidosis pathway also. So here I have made a chart. I'm approaching from metabolic acidosis pathway. So first step is to classify whether it's a high anion gap or normal anion gap. In a child with normal anion gap metabolic acidosis, the most common causes are GI loss, diarrhea, renal tubular acidosis, etc. So in our case, it was high anion gap. So high anion gap means there is some anion which is not contributed by the body. It's from external. So either it's a poisoning or it's an external acid. So the next step, we'll have to assess the urinary organic acids. Urinary organic acid, if it is abnormal, there are two possibilities. One, it could be an organic aciduria. Second, it could be an FAOD. FAOD is fatty acid oxidation defect. Now, what is the difference between both in presentation? FAOD, as I already told, FAOD is due to the defect in the ketogenesis. So they will be having high chance of hypoglycemia, and lactate is also high. In organic aciduria, hypoglycemia may be there, but most of the time it's normoglycemia. Lactate also may be increased, but sometimes it will be normal also. Now, ammonia is high in organic aciduria, not up to the levels of a urea cycle disorder, but organic aciduria will be having high ammonia, whereas FAOD will not be having high ammonia. Ammonia will be normal. Now, with an normal organic acid profile, if you are having high lactate with a normal glycemia, normoglycemia pattern, then we should be suspecting mitochondrial disorders like pyruvate dehydrogenase, pyruvate carboxylase, respiratory chain disorders, etc. Now, if you have increased lactate and hypoglycemia with a normal organic acids, then we should be suspecting gluconeogenesis defects like fructose 1,6-bisphosphate deficiency, etc., or glycogen storage diseases like GSD1. They will be having hypoglycemia and lactic acidosis also. Now, when I say about high anion gap metabolic acidosis, DK should be ruled out, but it's a pretty straightforward diagnosis because high sugar will be high, and poisoning should be thought of. This is a tabular column that how, based on the GLAC, you can classify grossly the disorders in a suspect case of IF. MSUD is maple syrup urine disorder, which is the prototype of the aminoacidopathies. They can have metabolic acidosis and hypoglycemia sometimes, but MSUD is one disease where the child will be sick, child will be having encephalopathic features, but all the GLAC and ammonia, blood gas, everything may be showing normal values. So in such a case, MSUD should be thought of, and MSUD can have particular imaging patterns. So that also should be looked into. Now, organic acids, organic aciduria, as the name implies, there should be acidemia. So metabolic acidosis definitely will be there. Hypoglycemia and hyperammonemia may be or may not be there. Lactic acidosis also may be or may not. Now, FAOD, the most important feature here is that ketones are low or at least not appropriate. So in the setting of low glucose, normal body reaction is to produce ketones, as I already told. So in the setting of a low glucose, if you are getting low ketone or inappropriately less ketone, negative ketone or inappropriately low ketone, that points towards FAOD. The only other condition that maybe you can get hypoglycemia with low ketones is hyperinsulinemic hypoglycemia, but that will not be having metabolic acidosis. Now, carbohydrate metabolism defects. Metabolic acidosis may be or may not be there, but lactic acidosis will be prominent. Again, for mitochondrial disease also, lactic acidosis may be there. So as I already told, encephalopathy without, you're sure that the child is having an IEM, inborn error of metabolism, child is encephalopathy, but all your glucose, ammonia, blood gas, everything is normal, then you should be suspecting MSUD. The other case is non-ketotic hyperglycemia, NKH. NKH is a disease which can present even in the early infancy with encephalopathy, intractable seizures, mostly myoclonus, sometimes hiccup-like motion, and all investigation except if you send plasma amino acid levels, everything will be normal in NKH. Brain may be showing some CC thinning or CC agenesis. Paroxysmal biogenesis disorders like Zellweger syndrome, etc. also all routine investigation initially may be normal. They can have hepatosplenomegaly. Pyridoxine-dependent epilepsy again will be having normal investigations. But pyridoxine-dependent epilepsy will be having along with encephalopathy, drug refractory epilepsy also. Coming to neuroimaging. This was the MRI of our index kit. This is the diffusion weighted images, and you can see bilateral GP was showing intense diffusion restriction, the corresponding ADC low images, low signals. T2 also was showing hyperintensity in the bilateral globus pallidus. Now we will have a brief overview about MRI in IEM. Not all IEMs with an acute presentation in the neonatal or early infancy. Urea cycle defects. The peculiarity is that they can have vasogenic edema. Most of the time we get cytotoxic edema, but urea cycle defects may show vasogenic edema in the MRI. And the pattern is that they will be, most of the time they involve globus pallidus and puttamina. And thalamus will be spared. And this pattern differentiates it from HI. There's a particular ribbon-like diffusion restricted pattern in the depth of sulci, which is described in urea cycle defects. These pictures are from Barkovich, not my own cases. Another peculiar feature is T1 hyperintensity in the insula. In this picture, you can see here in the insula bilateral, there is T1 hyperintensity. Basal ganglia T1 hyperintensity is there. Peri-Rolandic cortex hyperintensity in the T1. This is the ribbon-like gyral diffusion restriction I already told. So this pattern classically is described in multiple many urea cycle defects. And I should say this is the acute presentation. Chronic presentation or a later age presentation may not be like this. MSUD or maple syrup urine disease. The imaging of MSUD in the acute presentation is very characteristic. You see one case, you will not be forgetting that in your lifetime. The peculiar pattern is intramyelinic edema, and that involves the already myelinated structures. So at birth, the structures that are myelinated include dorsal brainstem, cerebellum, posterior limb of inferior capsule, etc. So that those structures will be having intramyelinic edema and intensely showing diffusion restriction. So these are variably described as 4-dot sign, hot cross bun sign, etc. And this is very peculiar for MSUD, acute presentation. Organic acidureas, the most common organic acidureas are MMA, methyl malonic acidemia, propionic acidemia, and isovaleric acidemia. MMA can have a predilection for GP, bilateral globus pallidus. Propionic acidemia and IVA variably involve basal ganglia. Mostly it is striatum, that's caudate head and putamen. White matter edema will be there, intracranial hemorrhages may be there. So this is the MRI of one of our follow-up case with chronic, it's like 5 or 6 years. But this child had a metabolic stroke in the infancy, and now you can see bilateral GPs initially showing T2 hyperintensity, that's a gliosis. This is very characteristic for methyl malonic acid. Now, glutaric aciduria type 1 is one of the most typical MRI picture, which if you see this pattern, there is no other DD apart from glutaric aciduria type 1. Here you can see there is subdural collection. Bilateral sylvian fissure is widened, which gives that a bat-wing appearance of sylvian fissure, and GP basal ganglia, this is a T1, so you will not see that. But this pattern is very characteristic. Clinically, the child will be having macrocephaly also, and also dystonia. This is another kid with GA1 proven. Bilateral, you can see posterior part of the puttamina, T2 hyperintensity is there. Bilateral GP, T2 hyperintensity is there. Bilateral sylvian fissure widening is there. So again, this pattern is GA1 unless proved otherwise. So coming back to a case, So the urine GCMS of our case showed a high increase in MMA. The plasma amino acid level show that he was having a plasma level of 754 when the normal value is less than 0.4. The TMS showed he was having less free carnitine, and we had sent a whole exome which was showing a autosomal recessive likely pathogenic variation MMUT, which is methylmalonic, which is the causative of methylmalonic aciduria. So MMA was confirmed for his case. Already I had shown about the relation between propranolol CoA and acetyl-CoA. So propranolol CoA will be converted to MMA, then it is converted to succinyl-CoA. There is another reaction in between. First it is converted to DMMA, then mutase converted to LMMA, then MMA is converted to succinyl-CoA. Sorry, not mutase, epimerase. So the most common, the major enzyme is methylmalonyl CoA mutase, which was mutated in our index case. Now this enzyme should have a cofactor, that's adenosyl cobalamin, for a proper functioning of this enzyme. Now where does this adenosyl cobalamin come? Adenosyl cobalamin is attached to this enzyme through some carriers. There are multiple carriers. CBL, cobalamin transporter A, cobalamin B, D2, F, J, there are multiple. So even the mutation of this carriers also can cause similar picture of methylmalonic acidemia. So propranolol CoA is converted to DMMA by propranolol CoA carboxylase, because propranolol CoA is a 3-carbon compound, MMA is a 4-carbon. So an extra carbon is attached by this carboxylase enzyme. All carboxylase enzymes will be having cofactors biotin, like pyruvate carboxylase also. So this deficiency of this particular enzyme will be causing propranolol acidemia PA, which is similar to MMA. So MMA can be two types, isolated MMA or MMA with homocystinuria. This mutation of this enzyme and this carriers can cause isolated MMA. Now there are some other cobalamin transporters like CBLC, CBLD, CBLF, J, etc., which can cause MMA along with homocystinuria. As I already told, this MMA presents after an initial normal period because the toxin need to be accumulated in the brain, accumulated in the body after a protein load. Lethargy, failure to thrive, recurrent vomiting, dehydration, these are not specific for MMA, but these any inborn error of metabolism can present like this acutely. Investigations, again, I already told, will be showing acidosis, ketosis, high lactate, elevated anion gap, hyperammonemia mostly will be there, but in our case, it was not there. Hypoglycemia, again, in our case, it was not there. Hypocalcemia was there. Particularly neutropenia, thrombocytopenia, and anemia will be there in our case. If you remember, I had shown the platelet count was 1.4 lakh 40 in the absence of any infection. So coming to the management part. While managing an inborn error of metabolism, there are two parts. One is the chronic management and one is the emergency management. Most of this IEM will be having acute metabolic crisis, and most of the time it will be precipitated by fever, fasting, intense exercises, some drugs like high-dose corticosteroids, etc., can push them towards acute metabolic crisis. So there are the main principle of managing an acute metabolic crisis is that. So we know that there is a deficiency of an enzyme and some metabolites are getting accumulated, which are toxic. So we need to prevent that toxin getting accumulated. And we need to prevent alternate energy and hydration. And if there is already accumulated toxin, we need to find a way to remove that toxin. So this is the emergency management chart. This is not specific for MMA. In any suspected case of IEM, if the child is in the ICU, you suspect an IEM, this can be followed. First thing is, we know that, okay, this is coming from the protein metabolism. So keep NPO so that protein load is not there. 10% extra infusion at a high rate at 6 to 8 mg per kg per minute should be started so that energy failure is not there. Metabolic acidosis should be corrected. If it's not getting corrected properly, then sodium bicarb can be given. Not only for correction of metabolic acidosis, but bicarb will be alkalizing the urine so that methylmalonic acid will be excreted more. If there is hyperammonemia, it should be managed with sodium benzoate or sodium phenyl acetate. And if it's not getting controlled, dialysis should be thought of. Now, cofactors, as I already told, propionic acidemia biotin can be given. In MMA, adenosyl cobalamin can be given. But in an emergency situation, we may not be able to pinpoint which particular entity is this. So the best thing is you can give cofactors liberally, because these cofactors will not be having any major adverse effects. You can just add the cofactors, and once the diagnosis is confirmed, you can remove whatever cofactors are not needed. Typically, what we do is carnitine. In any case of IEM, suspected IEM, we'll be pushing them with carnitine at a high dose. Pyridoxine, biotin, B12 injection, riboflavin high dose, and thiamine also. Again, you may be the primary caretaker, but when the child presents in emergency, he may be presenting in a nearby hospital where the doctor may not be exposed, the physician may not be exposed to managing such care. So what we do is, this is one of the chart of one of our patient where we give them this chart, and if at all any crisis is there, they have to present to the nearby hospital with this chart so that the doctor knows what to do. The main things are keep NPO, start IV fluid, 10% dextrose, maintain normal glycemia. Now, long-term treatment. So from the chart, it's clear that the starting point is 4 amino acids, mainly valine, threonine, methionine, and isoleucine, and also odd chain fatty acids. So the management involves restricting that. So it is very simple to say, but it's practically very difficult. So the main cornerstone of management of MMA is diet, which is low in these amino acids. Levocontin should be started. Vitamin B12 can be started. It may not be responsive in all cases, but we start in almost all cases. If there is chronic acidemia, sodium bicarbonate can be given. If there is hyperammonemia, ammonia scavengers can be given. Again, multivitamin supplements, calcium, vitamin D. These should be supplemented in all cases of any suspected IEM. Monthly course of metronidazole, because metronidazole, it is theoretically supposed to reduce the gut microbiota, leading to less propionate, leading to less metabolites. That's theoretically, but evidence is not there. Now, the index case, what was the clinical course? Currently, he presented 4 months. Currently, he's 18 months old, but the development age is 10 months. Total 9 admissions was there. Total 92 days of hospital stay was there. It constitutes 70% of his lifetime. There were multiple PICU admissions, overweight gain, but still he is improving. This was the levels of his plasma level. Started at 754 when he presented. Now, the last value was 12. But everything was not good. At 1 year of age, he developed discoloration of his skin and peeling and reddening, and he was so much irritable. This is the clinical photograph where you can see around the mucosal orifices also he was having such desquamation. So this is a condition which is known as acrodermatitis dysmetabolica. This is described in isoleucine deficiency. It is not specific for MMA where we are restricting isoleucine. In any inborn error of metabolism where we are restricting amino acids, like maybe in phenylketonuria, in MSUD, in all those cases, this is being reported, mainly due to isoleucine deficiency. So we recognize this, we started isoleucine supplementation, and there was a dramatic response. It started clearing by day 2, and this is the last photo. So what are the current concerns for him? There is failure to thrive. He presented at 4 months with a weight of 5.6 kg, which was 90th percentage. His current weight is 6.4. So in last 1 year, he gained 1 kilo. There is development delay, but he is improving. There are recurrent metabolic crises, and every time they have to admit the child. The family, they are very supportive. But they are coming from 100 kilometer far place, and no hospital will be accepting them. Once they are in metabolic crisis, they every time will be sending to our hospital. There are social issues, financial issues. So these are the current concerns. And long-term management options include liver transplantation versus combined kidney and liver transplantation. Currently, he is not having any involvement of renal. So we are not planning anything, but these are our future plans. I'll conclude my talk by presenting an interesting case, Patricia Stallings case. This happened in 1989 in America. Patricia Stallings and her husband, David, they were a novel-going couple at USA. Their life changed upside down when the 3-month-old kid had an acute episode of vomiting, crisis, and they presented to a hospital. At the hospital, the doctors diagnosed that the child was having antifreeze poisoning with ethylene glycol. Ethylene glycol is a component of this antifreeze. Antifreeze is used in Western countries to apply in the engine coolants to prevent coolant getting frozen. So his blood was having ethylene glycol, which is a component of antifreeze, and they suspected that it's a case of poisoning. So Starling's couple, they were the child was not given to them, but the child was given for foster care because they were suspected in poisoning. Now there was a second episode of worsening with fever, vomiting, and encephalopathy for this kid, which coincided with Patricia Starling's visit to that foster care. So this time it was clear that Patricia Starling is trying to poison the child with antifreeze, and Patricia Starling was sent to jail. And during that episode, actually, this kid Ryan didn't survive, and he expired. Now, Patricia Starling was given a first-degree murder case, and she was sent to jail with life sentence. Luckily or unluckily, she was pregnant at that time, and she gave birth to David Jr. Now, David Jr., the second child was transferred for foster care because again she is in the jail. Now, the second child at 2 weeks of life again started having the same symptoms that the first kid had: vomiting, lethargy, and encephalopathy. And this child was taken to a different hospital where the child was diagnosed to have MMA, methylmalonic acidemia. So, retrospectively, it was clear that the first child also was having methylmalonic acidemia, and the hospital and the lab, this was the gas chromatography of that kid. This is the peak of ethylene glycol, which is a component of antifreeze, and this is the propionic acid peak, which are very close. Propionic acid is also high in methylmalonic acid. So, for his case, it was misreported as ethylene glycol, leading to suspicion of antifreeze poisoning and all the happenings. So, this was published in Journal of Child Neurology also. So, the take-home messages of my talk are: one is unexplained lethargy and encephalopathy in the absence of infection should be investigated for an inborn metabolism. In suspicion of IEM, acute emergency management should be started even when the diagnosis is not clear, including giving cofactors. All suspected IEMs, GLAC should be done. So, if there one thing that you can carry from my talk, it should be GLAC: glucose, electrolytes, lactate, ammonia, ABG, ketones. All these investigations are easily available, and this help us to delineate and classify to at least which major class of IEM the child is belonging to. Collection of serum and urine samples for metabolic screening should be done as early as possible. Once the child is stabilized after 1 or 2 weeks, if you are getting a TMS, GCMS, actually it's useless. You should be getting that metabolites once the child is in the acute period. So there should be a high index of suspicion, and most of the time what we do is we used to keep TMS cards in the emergency, and if at all any suspicion is there, then itself TMS, this dried blood sport can be made. Also, urine should be sampled, should be stored. In proven case of IEM, emergency management plan should be provided, as I showed in our case. And last but not the least, in suspected case of inborn metabolism, as I showed in the previous case, trauma, toxin injection, and poisoning also should be considered. Thank you.
Thank you for an excellent presentation, Dr. Anand. Now I request Professor Vinayan to give his expert comments on the case.
Yeah, good evening. Thank you, Lakshmi, and thank you for giving this opportunity for our department. And Vaishak has presented the case very well, and he has highlighted all the issues in this case and all the issues in the rare disease scenario also. So if you look at taking at the rare disease concept at this point, most of cases in pediatric neurology will end up in the rare disease criteria because it is 1 in 2,500 or 1 in, if you make it the WHO criteria 1 in 1,000, most of our rare and complex epilepsies also comes into rare disorders. So the rare disease per se, it's not only the inborn metabolism, our SMAs are rare disease, and other neuromuscular disorders, named neuromuscular disorders, where there is a biomarker, genetic biomarker is a rare disease. Coming to this case, see, the problem is usually we think of the diagnosis. So diagnosis is one issue, and over the years I have seen that initially the problem was in the diagnosis. We were not able to diagnose it properly in the initial period, and Vaishak has given the clear points here to think of when a patient comes with an acute crisis, neurological crisis, when to think of a metabolic disorder and how to think of that. And based on that, we can take it into the next level. But the next point here is nowadays we are getting patients already diagnosed. So there the problem here is it is very difficult to manage these children. See, the protein restriction, it's easy to give a kind of a conceptual approach like protein restriction, give excess of fluid and then excess of energy and don't make them starving. But it is very difficult in a day-to-day practice. It's how much calories to be given, how much protein to be given. And when you are restricting the calories, immediately the families, what they do is they restrict completely. And then again, it will go into a crisis. Or if the patient end up with a chronic malnutrition. So this is one of the most difficult thing which we face nowadays, because previously some 10-15 years back, we didn't have the formulas freely available. Now it is much easily available. That many of these metabolic disorders, we have specific formulas, but how to use it, how to club with the regular diet, and how it should avoid an essential amino acid deficiency, like what Vaishak has told. In this case, we ended up with a essential amino acid deficiency in between. And so how to manage all these things is the most difficult part of it. But when you can do that, it's a difficult situation. We have to actually manage it in a multidisciplinary team. What we do nowadays is to discuss these kind of cases with our genetics team and in a multidisciplinary meeting with our dietitians, geneticists, and neurology team, and also if the patient is in the ICU with the intensivist, and plan a proper dietary plan and also a management plan so that we can take the child out of the ICU when the child presents with an acute metabolic crisis, and also to prevent further metabolic crisis, and also to maintain proper nutrition so that the growth and development is not that much affected, even though there might be limitations in many of the cases. But our aim is to maintain the growth and development as much as possible. And you know that when the neurological things in many of these metabolic disorders, the difficult part is, the limiting point is the neurological involvement. When there is significant neurological involvement, many of the definitive treatment like the liver transplantation and all those things may not work, because already the brain is damaged significantly, and whatever you do later may not help the child. So it is basically what I can say is that at this point, the overall rare disease scenario is emerging, and especially the metabolic disorders. Also, there is a lot of development which is happening, which we can do in our day-to-day practice. Families are willing to spend time and energy on this kind of disorder. So the best thing is to identify it early and then have a kind of multidisciplinary approach so that the best possible management and optimal growth and development can be achieved for these children. Lakshmi.
Thank you, Professor Vineyan. And there's a few questions. The Dr. Surendra Kosya, neurologist, has asked, OTC deficiency disease in young female as waxing encephalopathy. Could Dr. Anand, could you respond?
Yeah, OTC deficiency, it's an X-linked disease. It is a known case. It's one of the most common cause of urea cycle disorder. It can cause a hyperamonic crisis leading to encephalopathy. So it is very well known. In males, actually, it could be lethal or present as severe neonatal presentation. But in females, what all we had seen, they are young females with with fever and all. They will be coming with some encephalopathy, which they will be improving with proper ammonia reduction.
Dr. The Leber's hereditary, the triggers. Dr. Surendra is also
LH1 is a mitochondrial disease. It's not. It is not an acute disease. LH1 is a mitochondrial disease, which is kind of a chronic. Although there are some presentations of acute presentation like optic neuritis like presentation also is known with LHON, but LHON typically affects young males around teenage males with unilateral or bilateral optic nerve dysfunction. There will be no triggers as such as I am aware, because it's not an acute disease. It's not considered as an acute metabolic crisis.
Dr. Ramakrishna has asked, is there any specific EEG pattern in inborn errors of metabolism?
Actually, if we see the text in MSUD, there is a pattern known as POM pattern in EEG, but I don't know apart from that, I have never seen such a pattern.
Dr. Vinayan?
Yeah,
Have you
see, there are some metabolic mitochondrial disorders. We have specific things like RADS and the high amplitude. But the problem here is making a positive diagnosis of based on the EEG abnormality. It will be a little difficult.
At least suspicion.
We can have suspicions, especially a posterior high amplitude slow waves, which is coming periodically, can have suggestion of a Golgi disorder in specific mitochondrial disorders. So there are certain things like there are in the newborn period, if you have a abnormal what you call that in the preterm a change in the delta brushes. So abnormal delta brushes, if we get, it is suggestive of IEM, but it is again, it is not specific, I will say. So EEG, you can't buy it as a specific disorder, but usually in any case of toxic encephalopathy, you can get high amplitude slow waves, which are posteriorly dominant. So when you see that, it is suggestive, and you can get triphasics also in a case of hyperharmonic encephalopathy.
Okay, and finally, Dr. Sudikshan Vasudeva has congratulated Dr. Vaishakanath for a wonderful talk. So we have addressed all the questions. And any comments from the chairperson, sir? Professor Muralidharan Nair?
Yeah, I think he has really covered the topic and the case, very structured manner. It reflects the real complicated issues of management, diagnosis, So that is reflected in all these rare diseases, especially the delay in diagnosis, especially when it comes to real rare diseases. But since he has got an extensive, experience in this field, and and it is a multifactorial approach which he has said, and he has given us the real recipe how to really go through the whole thing. And I think there is a wonderful small book also by Clark on the clinical approach to IEM disorders. And he has given it very beautifully, the pathways, very, very elegantly. I think they all start with those pathways when they go to these various conferences. And I think the pediatric neurology is coming in a very big way, diagnosing these diseases, which are very, very, unusual presentations. So I just wanted to ask how soon you could make the diagnosis after the patient presented to you?
In this case, this was a straightforward case. He presented 4 months to our ICU. Already he was worked up from an outside hospital where he was proven to have acidosis, and the MRI pattern again that I already shown, it was very characteristic for MMA. The only odd feature for this kid was that we expected hyperammonemia in MMA, but for this kid, even now, hyperammonemia is not that much a high concern for him. So apart from that, it was actually a straightforward case. We suspected MMA only, and even before the MMA levels were available, we started him treating as acute metabolic crisis only, which we think that actually helped him a lot, because still he's not having any dystonia, because MMA can have bad dystonia due to this GP gliosis. But though he is having a mild development delay, he's not having severe dystonia till now, which we think that we had managed at the acute metabolic crisis very well at the presentation.
So is there a real drug of choice for this condition? For this MMA, any particular drug which will, is there a role for biotin?
Yeah, biotin is a cofactor of propionic carboxylase, not MMA. But what we do is, when we are not clear of the diagnosis, anyway, we will be giving the vitamins like biotin, thiamine, riboflavin.
So how much biotin you recommend?
We give 10 mg. 10 mg OD, sir.
Yeah. So is it available as a single molecule or is it as a multi?
No, no. It's available. 5 mg and 10 mg tablets are available.
Okay, correct.
Sir, the current issue now is when I started practice 20 years back, the diagnosis was a problem. But now the diagnosis is not a problem, sir. Diagnosis, most of the people are diagnosing, and now most of the referrals for us is already, like Vaishak was telling, it's already a kind of the approach was already there. Organic ischemia, there is already a diagnosis, or sometimes it is already diagnosed. They have done the genetic markers, and it's all available now. The only thing is we have to have an approach initially itself, and then the current problem is mostly what we are facing is the chronic management of this patient. Previously, we were actually diagnosing, and after that, what? That was the issue. But now it's not like that. It is this case, is these kind of cases. We have another patient of glutaric hysteria now in the ward. So that is also came with a severe malnutrition at this point, severe failure to thrive. So that is already diagnosed. But what to do next is the problem. See the formula, how to mix it up with the normal diet, how to make it up with the breastfeeding. So unless you do it properly, there is going to be a problem now. So the early diagnosis is happening now. Especially in Kerala, I can say that over the years, the early diagnosis is happening now, much earlier than which was before. But to take it to the next level, we need more expertise in managing these children. And then, like Vaishak has pointed out, it's a kind of a roller coaster drive because there is a limitation of the enzyme. So some of the children will develop some bypass strategies or bypass enzymes after some time. So the children will be able to, we may be able to sustain them. But some of the children, we reach a real ceiling. Beyond that, we are not able to support them. But nowadays, I feel like if you start properly with a proper approach in fluid, electrolyte, and protein and calories, we will be able to sustain many of these children. And many of these children without much, again, as Vaishak was pointing out, without much neurological damage. Once the neurological damage is set in, then the support of this kind of support is going to be of not much value.
Professor Gagandeep, sir, your comments?
Yeah, I mean, as an adult neurologist, it's not something that we see very often. Of course, I think the other aspect about these rare disorders, and particularly neurometabolic disorders, it might be perhaps too late, but then as adult neurologists, I feel that we need to have the right kind of exposure so that these rare cases which transition into adulthood, we must be really aware about these, and those cases which have been missed in the childhood for obvious want of diagnosis and expertise, the kind of which Dr. Vinyan has mentioned, and he probably has much better than anywhere else in the country. So I think we also need to pay a little more attention to what happens as these people, special people transition into the adulthood. And that's something that I have to say. But the case was absolutely wonderful. Congratulations, Dr. Anand, and congratulations, Dr. Vinyan, for an excellent case and presenting the entire spectrum of neurometabolic disorders and their clinical radiological presentations. Thank you so much.
Sir, thank you for Vinayan and Vaishak Anand for joining us in the inaugural edition of this webinar series in the rare disease occasion. Next month, we'll meet with another new case. With a concluding question to Dr. Vaishak Anand, do you think enzyme replacement therapy is on the horizon for most of these inborn errors of metabolism? Do you think they are on the horizon?
Not for most, sir, because enzyme replacement therapies, it is a point of care for state of the art for many of the IEMs like Gaucher's disease, Popeye disease, etc. But not for this intermediate metabolism. These small molecule diseases, none of them are having this enzyme replacement therapy. I think it may be.
Do you foresee that in future?
You can foresee, sir, otherwise there is no hope. If there is no hope, you can't go further. No.
Thank you. So we conclude this session, sir, with the permission of the chair. And thanks for every one of the participants who joined. And I'm sure that it's a real intellectual feast for all the residents. Thank you. Goodbye. Meet you next month.
Thank you. Thank you.
Good night. Good night.